Good afternoon. My name is Sarah Fuchs, and I'm a senior specialist for the Community Education Department at MDA. We are thrilled to have you join us for day 2 of the MDA Virtual Learning Series on SMA. This learning series is a part of our larger MDA community education programs, which focus on bringing the neuromuscular disease community together around education and resources. Be sure to visit the community education section on mda.org for updates on upcoming events. We are recording today's event and will be posting it to our website for on-demand viewing at a later date. Everyone registered for today's session will receive that information in their email inbox. Please know that all phone lines have been muted, but you can still ask questions. Please use the chat feature to type in your questions anytime during the presentation. We'll be sure to collect those and address the question at the end of the presentation. I also want to encourage everyone to complete the survey that will automatically pop up when you leave the webinar. Your feedback is important to us and it helps to shape our future programming. I want to extend a special thank you to our program supporters, argenx, Biogen, Genentech, and Novartis. For nearly 75 years, MDA has led the way in funding research to accelerate the development of new treatments, expanding access to care and clinical trials through the MDA Care Center Network, and advocating for access and inclusion for the neuromuscular disease community. MDA delivers its mission through research, access to care, advocacy, education, recreation, and engagement. Since its inception, MDA has invested more than $1.1 billion in neuromuscular disease research. Our MDA care centers are located at over 150 top medical institutions nationwide, providing care from clinicians who specialize in neuromuscular disease. MDA's advocacy work focuses on support for accelerated approvals and novel research, access to healthcare, accessible air travel, and more. This focus plays a vital role in shaping laws and policies that support the needs of people living with rare neuromuscular diseases. Our community education and recreation programs are designed to connect individuals and families. We are committed to building a nurturing environment where our members can share experiences, triumphs, and challenges. Every year, we offer over 40 educational programs and over 20 summer camps, along with dozens of other community activities, both in person and virtually. Now it is my pleasure to introduce today's first speaker, Mark Sketch. Mark is a dedicated respiratory therapist with over 16 years of experience at Cincinnati Children's Hospital. He specializes in outpatient care for pediatric and adult patients with neuromuscular disorders and has proven expertise in the implementation and evaluation of advanced ventilation and airway clearance strategies. He is actively engaged in clinical research initiatives and protocol development to improve respiratory outcomes for complex neuromuscular populations and has been recognized for collaborative interdisciplinary work. Mark has a deep commitment to advancing respiratory care in both clinical and research settings. Mark, thank you so much for being here today, and I will now turn the time over to you.
All right. Thanks, Sarah. I appreciate that. Just lost my, hold on just one second here while I get this back going again here. Are you able to see my screen? Sorry.
No screen yet. I can see your video, though.
Okay.
I can see you. No screen yet.
Okay. Hold on just one second here. So that, all right.
Alrighty, I do see a screen.
Okay. And then just, okay. Sorry, guys. I'm just gonna get my notes here together. I had this going, and then
Oh, just click the little PowerPoint one there on the right. The bottom icon on the right of the screen.
why is that not coming up now? It's coming up before and now.
So if you just move your mouse a little bit to the right where there's that PowerPoint icon,
Yep.
is nothing coming
Okay.
up?
So it was up there, and now see if I can get that to move again. All right, hold on just 1 second here. All right.
There we
Okay.
go.
Are you able to see it now? Okay. All right. I apologize. Um, so, yeah. So again, thanks for the patience on that. So, yeah, again, I'm a respiratory therapist at Cincinnati Children's. Been doing this for about 16 years, with dealing with different types of neuromuscular diseases. So, I just want to quickly just go over the respiratory complications associated with SMA, and then describe the strategies for respiratory support. And then finally, we're going to go over some collaborative care and just go over the key roles of the providers that are involved in caring for patients with SMA. So, what are the respiratory complications in SMA? So, first we have restrictive lung disease, we have impaired cough, we have recurrent infections, and then the last two are sleep disordered breathing, and then chest wall and spine deformities. So, I want to take on these individually and just go over each one, and kind of just explain our processes and how we, what we do to mitigate each one of those things that happens in during the process of SMA. So what is the normal breathing function? So in normal breathing, the diaphragm, it contracts and moves downward. So what that does is expands the chest cavity, so that you can get proper airflow in. So the intercostal muscles are also involved in that. They lift the rib cage, and that increases the chest volume, which allows for airflow to go down in the lungs. So what does restrictive lung disease do? So in SMA, restrictive lung disease, it causes diaphragm weakness. So when you have reduced chest expansion, then you have lower lung capacity. Then obviously you're going to have the ability for air to get into the lungs is decreased, and then you start to have some issues there. So I've included two slides here, or two pictures here, that show, so they're CT scans that we've done on two different patients. So one is a SMA patient that has restrictive lung disease. So you can see the airflow at the top here is not getting into the deeper parts of the lung. So that's why you're going to have the almost the misshapen lungs here, where you're not getting air flow down in the deep bases of the lungs, because because it's restricted from going in due to diaphragm weakness. And the other thing, again, the intercostal muscle weaknesses cause a stiff chest wall, and so that restricts airflow, and then you have a higher chance of lung collapse when that happens. So impaired cough. So what happens there is you have an inspiratory weakness. So that interferes with the ability to generate a large inspiratory volume during the first phase of the cough. And then poor glottic function. So the glottic, basically, if you think of it like open a toilet seat, when the toilet seat closes, that's how you're going to be able to get a good cough. Well, In SMA, when you have poor glottic function, the glottis does not properly close, and so the inability of the glottis to close during the compressive phase that limits the generation of adequate intrathoracic pressure that's involved in the cough. And then lastly is the expiratory weakness. So expiratory flow velocity is compromised during the expulsion phase of the cough, and so the cough is much weaker, and then the ability to expel mucus and debris that's down in the lower base of the lungs is diminished at that point. So another thing that happens with SMA, and what we're very concerned about, is the recurrent infections. And what's that due to? So that's due to the inability to clear secretions effectively. And the other thing that goes into that is the chronic dysphagia and aspiration. So oftentimes with poor swallowing, some of that mucus or some of the phlegm that's in the upper part of the throat can sometimes just go into parts of the lungs that you don't want it in, and so that also leads to aspiration. And then when you have these things happening on a chronic basis, then you end up with chronic pneumonias and bronchiectasis that also go along with that. So another thing that happens that we're very concerned about with the SMA population is sleep disordered breathing. So you might see respiratory pauses when they're breathing. You're going to have periods where there's no breathing at all. And so if you're starting to see this with your loved one, that's something that you probably want to let your primary care provider know, or a pulmonologist if you have one. Definitely want to let them know, hey, this is going on. We definitely want a sleep study to see if there's any signs of sleep disordered breathing that are really causing my child or loved one to reach higher levels of CO2, or are they waking up a lot? They're getting an unrefreshing sleep. And so that's leading to the daytime sleepiness, almost like an irritability that you might see. And then the other thing that may happen too is that the snoring may be absent. So with a lot of times that we associate sleep disorder breathing with snoring, but that may be absent. Why is that absent? So it requires a sufficient muscle strength to generate an airflow. And so when you don't have that significant muscle strength when you lay down, then that airflow can be restricted. So you may not hear that snoring that you normally would think that you would hear. And so that's why you definitely want to be vigilant of these type of things if you're seeing that happen. And then the last thing that happens is the headaches on awakening. So that can cause like irritability, that can cause stress in the morning. And so many times, this can really lead to issues throughout the day. You may see almost a tiredness to where they are wanting multiple or frequent naps, even in the morning time. Shortly after they've woken up, maybe an hour and after they've woken up, they feel like they want to nap again. So that's definitely something that we're on and want to continue keeping a constant monitor on, just to make sure this isn't happening. So chest wall and spine deformities. So this can happen often, especially in your SMA1 population. So I've included three visuals of exactly what I'm talking about. So that bell-shaped chest, if you look at that first photo here, so you can see the bell-shaped, whereas the lower part, so where the diaphragm involvement is, you'll see more. You'll see there's more expansion down below, but up top, It's got that bell shape to it because the intercostal muscles can't stretch, so they're not pliable. So that causes issues over time to where it can restrict breathing. So you'll see, like I talked about before, the restrictive lung disorder and disease that comes out along with that. And so that's something that that obviously we're concerned about at that point. And we're looking at interventions to really stop that from happening. The second thing that happens is the scoliosis. So you'll see the S shape. So we define that as curvature. So depending on how much curvature that we're seeing over time occur, that can really start to restrict how much airflow gets into the lungs. And so if you have a high degree of curvature, then you're going to start to see more CO2, carbon dioxide retention from those type patients. And so that's something that definitely a sleep study would show whether the scoliosis was affecting how much airflow is actually getting in. And then the last thing is the parasol rib deformity. So better known as the collapse of the rib cage. So we're seeing this on the third picture here. Basically what's happening. So if you think of an umbrella, when it's opened up, but it's more at the top, it's more narrow, but at the bottom, it's more open. And so that's starting to happen as well. That goes along with the bell-shaped chest that I mentioned before. But these three things, the chest wall and spine deformities, really can have a huge impact on oxygenation and also, even more importantly, the ventilation that's occurring in our SMA population. So we just talked about all the complications that happen in SMA, but now we want to talk about the strategies that we use to mitigate what are happening in the complications that I discussed. So the four major ways that we use to enhance respiratory support and to give our patients a better way of breathing is through mechanical ventilation, airway clearance. We use nebulized medications, and then lastly, we use airway suctioning to clear our airways. So first, I'll start with mechanical ventilation. So we at our hospital, we use bi-level positive pressure ventilation, so also known as BiPAP. So we do not use CPAP at our hospital, mainly because we need pressure when inhaling as much as we need pressure when exhaling. So the pressure when exhaling, that's basically just keeping constant pressure in the lungs to keep the lungs open, but you need inhalation. So what bi-level positive pressure ventilation does is it has a backup rate to it. And so that backup rate actually helps support when in the presence of shallow breathing or no breathing. And so over a minute, when we set that rate, that the SMA patient is actually going to get at least whatever amount of breaths that we set for them to get. So that's inhaled pressure breaths that help with chest expansion. So we're very proactive at our hospital when using any type of support, mainly because we're looking to mitigate those symptoms and avoid respiratory failure. So one of the things that we also look at too is mitigating that chest wall deformity that I talked about in the last slide, and then also allowing for when any of us lay down, our breathing does slow down, but in SMA patients, it can really slow down, and their ability to take a deeper breath at that point is really not going to happen as they get weaker. So it's definitely something to keep in mind, as you talk to your primary care provider and also your pulmonologist, to get a pulmonologist involved early to take a look at these things, to see if it's something that do we take a more proactive approach here and help with breathing versus standing back and kind of letting things happen and see if the breathing is going to slow down to the point where it's not really supporting them as it should overnight. So, and lastly, we prefer at our institution nasal masks over full face masks because there's a higher chance of aspiration. So if you think about it, if you have more mucus in the upper airway, or if you have more phlegm that's located in the back of the throat, that what's going to happen is that bilevel ventilation is going to push that down into the lungs, or it could push it down the lungs. So we prefer the nasal mask over the full face mask, just because you have a better chance of using a suction device to suction the airway out during the night when they're sleeping, so that that mucus does not get down in the airway. So I've included just a slide here of two different devices that we use. So the one on top is a ResMed BiPAP. And again, what it provides is inhalation pressure as well as exhalation pressure. It also comes with a BiPAP, also comes with a backup rate. And then the other device that I included here was a ventilator. So a ventilator does offer a higher level of support. So in respiratory terms or pulmonology terms, what we talk about is more of it having a support for every single breath versus just the rate that's set. So if your child or loved one is breathing more times than just what the backup rate allows on the BiPAP, then the ventilator can actually give a little bit more support on those higher breaths that go above that rate. So one of the things that I do in my outpatient clinic is I teach airway clearance. And so there's a couple different ways in which that we do airway clearance and devices that we use for airway clearance. The first one, we can do CPT or chest physiotherapy, which is mainly patting on the chest to mobilize the mucus in the lower airways. And then some patients we put on a vest, which is more like a wrap, and I can show you that in the next slide, which does basically the same thing as chest physiotherapy does, but without all of the labor that's involved in it. So we can initiate either one of those two types of airway clearance treatments on our patients, and both of those again are to mobilize the mucus to get it to the point where we use the next thing, which is called the cough assist. So that provides both insufflation and exsufflation. So insufflation meaning that we get air under the mucus, and then exsufflation meaning that we remove the mucus or get it to an upper airway where it can be suctioned out. So what the cough assist does, again, it maintains the clear airways. It also can prevent atelectasis and pneumonia. So atelectasis, like I said before, with the restrictive lung disease that's involved in SMA, what happens there is you're not getting airflow in the deeper parts of the lung, and so with that insufflation, you're aerating the lower parts of the lung and removing mucus that can cause pneumonia in those lower bases of the lungs, and actually moving into the upper airway again, like I said, where you can suction it out. The other thing the cough assist can do is it could prevent chest wall deformity. So again, over time, as you have weaker intercostal muscles that are involved in breathing, that insufflation part can really help for chest expansion because you have poor compliance. So when you use a cough assist, the outside pressure coming from the actual device itself is able to overcome the restriction that's happening with the chest wall, and actually you're getting chest wall movement from the cough assist itself. And then the large volume breaths, that kind of goes into that too, so that mobilizes the rib cage, and then it also can keep the joints flexible and pliable. So this slide basically just highlights the different types of airway clearance that we use here at our hospital. So we use chest physiotherapy. You can see that on the left-hand side here. So basically we can use a bulb type of device, and we pat, you can pat softly or a little bit more hard, obviously not going to make the child uncomfortable. But again, what that's doing is it's mobilizing mucus. So it's getting it off of the airway, the walls of the airway, so that when you end up using the cough assist, it's working more effectively. So the slide in the middle is just the vest. You can see the wrap there in the middle that really uses the same type of vibration strategy to really remove the mucus and debris from the lower airways more to the upper airways. To finally, we're using the cough assist, and the cough assist really is used at that point for, again, like I said, secretion removal. So it's really good at removing mucus that's located in the airways once it's shaken up by the vest or the CPT, so that you're getting it's enhancing the overall treatment that you're giving. So inhaled medications is the next thing that we use in our airway clearance strategy. So we use albuterol. I know albuterol a lot of times is associated with asthmatics, but we can use albuterol. We use it as a bronchodilator, so it opens the lower airways by relaxing the smooth muscle. And so when you do that, then your secretion clearance, or the amount of air that you can get underneath the mucus is definitely enhanced at that point. So again, in the notes there, I always say you use any bronchodilator before you do airway clearance, again, to open it up. And then, what we usually do though is we use the bronchodilator, then we'll use, we'll hydrate the airway with either normal or hypertonic saline. So that works to really loosen the mucus. And that can also work to get it off of the bronchial walls too. And again, we use that with cough assist, and we can also use the saline with suctioning as well. Another medication that we use is ipratropium bromide. And what that does is that reduces the secretion load. So, some families will tell us it's drying my child out, so we don't use it as much. But again, we can use it if you're starting to see a lot of buildup of secretions in the upper airway. A lot of times we're trying to dry that out. So a lot of the mucus that you see in the upper airways are not going into the lower airways. So again, we can combine that with albuterol. So what's called a dual neb. So dual neb includes albuterol and ipratropium bromide. Again, it's doing both of those functions, where it's opening up the airway, but it's also reducing the secretions that are happening that can get into the lower airway as well. And then higher level, so with infection, we also can use inhaled antibiotics. Mostly we use tobramycin, also known as Toby. And so that helps treat pneumonias in chronic respiratory infections that we often see in the SMA population. So when you start to see higher levels of bacteria, or your pulmonologist has recommended that you do an X-ray, and you're seeing a buildup of mucus down in the airway, we may elect to do the tobramycin to really start to help the patient with SMA not have as many secretions down there that are causing the pneumonias, the constant pneumonias that they're having. So this is a portable suction device, which I've shown here in this slide. So this actually will attach, the end part will attach to either a Yonker device, which is a plastic suction piece, which helps to remove secretions and mucus from the oral pharyngeal section, and then also nasopharyngeal. It provides an easier access to the back of the throat. So we use suction catheters at this point. So what I teach my families to do is use an 8 French or a 10 French suction catheter, and actually put it into like a water-based what we call Surgilube. If we put it through that, then it allows the nasal passages that can sometimes be not easy to access. So when we use the Surgilube, we're actually able to, that allows the suction catheter to get back to the back of the throat through the nasal passages. So if your nasal passages are either really dried out or they're very narrow, the Surgilube, if you put it on the suction catheter, then you're able to actually move the suction catheter through the nasal passages to the back of the throat, where you can actually suction out large amounts of mucus easier if you're not able to get it with a oral pharyngeal suction. So again, going back to that picture there, that is a portable suction device. So it works off of a charge. So if you charge it at night and use it all, you can use it all day. I think usually most of our portable suction units last for up to 8 hours. So just something to keep in mind to have, or ask your pulmonologist to write an order for, because they're definitely great to have around as you try to remove mucus from the airway, so that it's constant, so you don't have the constant buildup when you're out and about. And then lastly, I'm just going to go over the collaborative respiratory care in SMA. Just going to go over the vital roles that the pulmonologists, the respiratory therapists, and the primary care providers all play in the care for our SMA patients. So the role of the pulmonologist. So the first thing they do, they can conduct lung function assessments. So a lot of times when you have a visit with your pulmonologist, they will order what's called a PFT, a pulmonary function test. And so what that allows you to do, or what that allows them to know, is how much airflow is actually going in and out of the lungs, and through the airways in a normal breath, also with a cough, and even with deep breathing. And the other thing they may do is they may order sleep studies. So like I said before, sleep studies are for patients, again, that we might be proactive about in trying to assess any type of sleep disordered breathing. So the pulmonologist is really involved in both of those type of tests that happen in our SMA patients. The other thing is that they can develop ventilation strategies. So, we use both BiPAP, and we also use non-invasive and invasive ventilation strategies as well. And so the pulmonologist is heavily involved in both of those strategies to come up with the type of settings that we're going to use, the type of respiratory rate that's going to be needed for those types of patients. And so they monitor them through, CO2 monitors. They can also look at downloads that come straight off of the machines that we use to be able to determine if we are ventilating the patient with SMA effectively. And then the last thing they do is they manage acute respiratory infections and long-term respiratory decline. So Again, taking a more proactive approach when you're seeing an acute respiratory infection happen, reaching out to them, letting them know what's happening, and they can in turn let you know whether they need to get something higher level, like a vest or a cough assist involved, or do we need to change settings if you already have those in house. Or again, there's nebulized medications that I talked about before. So that's something that, do we need to get tobramycin, started for these type of patients, or is albuterol necessary to open up the airways? So these are the type of things that the pulmonologist is heavily involved in and making decisions with, and they take an active role along with the respiratory therapist in making these types of decisions. So the role of the primary care provider. So what they're going to do is they're going to coordinate routine care and vaccinations. So I will take this opportunity to say, we're coming into cold and flu season, so definitely get your child or loved one a flu shot, and then also be on board if they call up for a pneumococcal vaccine as well. Those two vaccines I've seen in my care, in my time here caring for patients. Those two have had a very big impact in stopping some of the infections that we've seen happen in our SMA patient population. So definitely listen to your primary care provider if they are pushing those two vaccines and other vaccinations as well. So the other thing they do is they monitor for early signs of infection. So early signs of infection can be an upper airway infection where you're seeing more of a green tinge mucus that's coming from the upper airway, like the nose. And so when they're seeing these sorts of things, they're probably letting you know, hey, there's something really going on here. They can test it. They can do a nasal swab, if you go in to see them. The other thing they can see is the respiratory decline that may happen from an infection, or even if they're seeing signs of decline that are happening in a point where in a non-infection when it's just the patient is at baseline. So primary care provider can a lot of times identify these types of things and let the pulmonologist know, hey, there's something really going on here as far as from a respiratory standpoint that I am concerned about, and I'd like you to take more of a higher level look at that. And so at that point, that's when they're usually asking for you to probably see your pulmonologist in a very shorter time frame than you normally would. And then again, they serve as a liaison between the specialist and the family. So a lot of times, what they're seeing on a clinic to clinic basis, we because we may not see them as often, that's something that the primary care provider can definitely let us know. Like I said before, if they're seeing higher level signs of decline, or they're seeing the early signs of infection, that's when they can get other specialists involved. So definitely, the primary care provider is a very important part of the collaborative care that is happening. And then the last thing, I'm a little bit biased here, but being a respiratory therapist myself, what I work to do is I develop airway clearance strategies. So I look at whether vests and cough assists are needed, and then I look at the settings. I'm also, in constant contact with the pulmonologists about these things, whether these airway clearance strategies are working. Do we need higher level? Is it a settings thing? These type of things, the respiratory therapist is definitely going to be involved in your outpatient clinic visits, and also from an inpatient side as well. If you're getting discharged, the respiratory therapist is definitely working to make sure that you have the right settings as you're going home if you've been inpatient. But your outpatient respiratory therapists are also working to make sure that they're trying to keep you from getting admitted to the hospital. So definitely worth listening to them. And you can always, reach the pulmonologist and say, hey, I'd really like to get the respiratory therapist involved, and see what their thoughts are on, the way in which we're doing airway clearance, whether this is working or not. And so these are the type of things that I offer in our clinic, that I've done for a very long time that have really helped our patients. So the other thing I do is I train the families on use of cough assists and home ventilation devices. So if we're initiating a cough assist or a vest or a BiPAP or a ventilator, that's one of the things that I'm heavily involved with. So I'm training the family in clinic, but I'm also placing a follow-up call, just to make sure that the settings are adequate, that the child is doing well on those, that they're, if it's a cough assist, are we getting a productive cough? Are you getting mucus clearance with it? Are you seeing good chest rise? These are the type of questions that I ask my families a lot when I'm making follow-up phone calls after I initiate any type of device in clinic. And then the last thing I do is I monitor home ventilator support and then airway clearance. So I touched on the airway clearance, but I'll go through the ventilator support. So what I do is I'm able to get a remote download from the BiPAP or ventilator that the patient is on, and I'm able to see how much airflow that we're actually generating, and so and realizing whether we're fully supporting them, and so that really works hand in hand with us making changes if we need to, and so over time, the ventilator support, as the patient gets bigger, and or if they're getting a little bit stronger, we're either weaning support, we're increasing support. These type of things can make a huge difference in between clinic visits. Some clinic visits can occur 3 to 6 months out, and so having a respiratory therapist that's heavily involved in these types of things can make a major difference. And then lastly, I just want to highlight the importance of collaborative care. So seamless communication is going to improve patient outcomes. I can't stress that enough. When the three prongs of what I just talked about in the collaborative care are heavily involved, it's the patients that benefit, and it's the families that feel so much better about the direction of their child or loved one. And then early intervention strategies are needed to prevent any type of hospitalization. And so, getting those on board as early as possible, when those three are heavily involved, knowing when something's happening and when to intervene is extremely important to prevent an inpatient stay, and can really mean the difference. Really provide a huge difference when it comes to the care of the child. And then the family center approach, we stress this very, very seriously and highly at our hospital here. It improves quality of life, and not just for the patient, but also for the family. All the worrying, all of the things that go involved that are involved in taking care of patients on a day-to-day basis with SMA, can really be put to rest when you have all three of those caregivers involved at a high level. And so, we're there for the patients, but we're also there for the family and caregivers there as well. And so, lastly, I just want to stress that interdisciplinary teams ensure proactive, but just not reactive care. So, always be proactive in the care. And to my SMA families, I would tell you to always, be looking for, ways that to take care of your child, and always involve the three that I talked about. Always involve the primary care physician. Always involve the pulmonologist. Always involve the respiratory care, the respiratory therapist, because taking a more proactive approach when you're open to doing that and pushing us to do it, that really does make a huge difference in the overall quality of life for our patients with SMA.
All right, so we have some questions that came in from registration. So the first question that we had that came in was that you mentioned, let's see, how do you avoid oral thrush when using an inhaler?
Yeah, that's a great question. So you want to do mouth care if you can. So there are mouth care kits that are available. So a lot of times, like I said before, with the suction machine. So after you give the oral inhaler, there may be some of that is, some of that debris that's still up there. So having a suction machine definitely helps with some of that, because some of that thrush can develop in the back of the throat. So if you're able to get any types of anything that can, like I said, suction the back of the throat, but oral care definitely helps with preventing thrush as well. So there are some there are devices that can be used with the suction machine that brush but also suction. So those both can be used. So oral care kits can be ordered through any of your DME or home care company. And so, that's definitely something I would ask your primary or your pulmonologist about, if you're concerned about that.
Wonderful. Thank you so much. Let me get to another question that we had. Should we track oxygen levels or breathing at home? And if so, how should that be done?
Yes. So there are portable oxygen saturation monitors that are out there. They are expensive. So um, you can also order or I say actually talk to your pulmonologist about ordering a pulse oximeter machine. And so those are much easier, and a lot of times are covered by insurance. And so that's something that you can leave on your child or loved one at all times. And so you can definitely monitor oxygen throughout the day, and then even more importantly at night. So when they're on support overnight, whether it be a BiPAP, ventilator, whatever, you can use a oxygen saturation monitor to closely monitor that. And it also that comes with alarm settings. So if it falls below the threshold, whatever you've set, a lot of times we set the threshold at 90% for our patients. So if they fall below 90%, then you'll hear an alarm go off. And those devices also can be reviewed to see when those oxygen desaturation events happened.
That's very helpful information. Thank you so much. We had another question that came in. Are there measurable improvements in breathing with the therapies that you mentioned?
Yes. So especially with when using the bi-level ventilation that I talked about, Those strategies have definitely worked for both ways. So first we look at breathing in two ways. So when we look at ventilation, so how much when we breathe in oxygen, we blow off CO2. So if you're having, you can have oxygen desaturations if you're not breathing effectively. But the other thing you can have is CO2 retention. And so if you're not blowing off enough CO2, when the child or loved one is laying flat or even sitting up, then those type of devices can help during the day. One thing I should mention though, when they do become sick and weaker, your ability to take deeper breaths is definitely inhibited. And then the other thing is, you can use those devices to help with with taking some of the load off that happens in a sickness or an illness. But even when your child or loved one is not facing an illness, those devices work very well as far as to provide ventilation. The other thing that is the cough assist machine, like I said before. So when in patients that have poor chest wall mobility, so their ability to cough or their ability to inhale is compromised, then a cough assist device can help remove mucus, but also can help provide larger airway breaths, so that they're getting chest wall expansion in addition to removing mucus from the airway.
Very good to know. Thank you so much for sharing that information. Let me see just a moment. I'm looking through the document of questions that we received. Um, we had one that is related to disease-modifying treatments. So how do disease-modifying treatments like Spinraza or Zolgensma, et cetera, affect pulmonary or respiratory, function?
Great question. So these are newer treatments. And so when we have seen that in some cases where yes, you're getting better mobility in sometimes in your arms and legs, but sometimes your chest wall mobility is still compromised even when you're getting those types of medications. So it is important to consistently see pulmonary on a consistent basis, so that they can go through, like I talked about before, the pulmonary function tests, also the sleep studies. Those are very effective at allowing us to know whether higher level ventilation is needed or cough assist treatments are needed. So yes, Spinraza has been great and it's been a game changer, but in not every case will you see from a respiratory muscle standpoint, that ability come all the way back. So it is important to be in contact with your pulmonary providers about these things, and go through these types of tests, so that if any type of breathing has been compromised.
That's really interesting and important to know that information. I could see how maybe if you're experiencing better function in other ways, to think that maybe that's not quite as important to see the respiratory set, for that set of things. So thank you
Correct.
so much for sharing that. That was actually all of the questions that we had that came in. I am very thankful for you for being here today with us and for the information you're able to share with the community. I'm sure they were very thankful for that as well.